Okay, so hola y buenos días a todos. Soy Donald Mason de Waters Corporation. Lo siento mucho que no puedo presentarles en español, pero mi español es muy limitado. But I thank the organizing committee for the opportunity to present this brief overview of the role of mass spectrometry in newborn screening. And I thank the organizing committee for having a translator available.
Thank you, Dr. Mason.
My slides are not advancing. I do need to disclose that I am an employee of Waters Corporation, and any of the information that I discuss today is designed to be illustrative and not a product positioning. So today I'd like to cover 6 main topics related to the use of mass spectrometry for newborn screening. I'll provide a very brief overview of some of the early days of newborn screening, including a quick review of the Guthrie test for phenylketonuria. I'll talk about the rise of mass spectrometry-based testing for newborn screening. And I will provide a little bit of information about the efforts in the United States towards a recommended uniform screening panel of disorders. And then I'll quickly highlight some of the progress that has been made in the countries of Central and South America. And then finally, I'd like to touch on the use of mass spectrometry beyond the first-tier screening for inborn errors of metabolism. And at the very end, there is a single slide that hopefully provides you with some helpful resources. The picture that you see on the right, dated the 3rd of June from 2003. This is my oldest daughter, Noelia, as she was having her dried blood spots collected for the newborn screen in Massachusetts. At the time, I was working with the newborn screening lab in Massachusetts as they were adopting the use of mass spectrometry for newborn screening. So I obviously had an interest in ensuring that the dried blood spots were collected appropriately, which you can see here, and then following up with the testing.
Thank you, Dr. Mason. Muy brevemente, reconociendo que ustedes son estudiantes de medicina y saben bastante bien en inglés, no voy a pasar en detalles chiquitos aquí. Estas son 6, digamos, metas. Básicamente es la historia, explicar el uso aumentado en mass spectrometry, la obligación de eso, el progreso en Centro y Sudamérica y las últimas 2 nos va a explicar. La foto al lado derecho es de su propia hija en 2003 y tenía mucho interés en hacer esa prueba. Entiendo que no salió positivo, salió negativo, entiendo, y mencionó eso. You can take it back, Dr. Masson, please.
Okay. So I am sure that you all are familiar with phenylketonuria, as it is one of the very first inborn errors of metabolism to be described and to be understood. As I'm sure you know, it is a disruption in the phenylalanine hydroxylase enzyme that leads to the accumulation of phenylalanine and its metabolic byproducts, phenylpyruvate, phenylactate, and phenylacetate, that are neurotoxic and can lead to severe mental retardation in patients who are not diagnosed with PKU. In addition, and this will become important in a few slides, we also see a decrease in the amount of the amino acid tyrosine in patients with phenylketonuria or PKU from here on.
Este slide es un resumen de la bioquímica. Está ahí presentado y eso hago referencias a lo que ustedes han estudiado y no paso más tiempo. Entonces, Sigue, por favor, doctor. Go ahead.
So I enjoy going back and looking at some of the older scientific literature, and this is the first paper published in Pediatrics in 1963 that describes a simple method for the quantitative measurement of phenylalanine in large populations of newborns. So this is the paper from Dr. Robert Guthrie, who was in Buffalo, New York at the time. His method was actually first described in 1961, so not to a population of newborns, but rather to over 3,000 institutionalized patients. And from that population of patients, there were 21 cases of phenylketonuria that were detected, which was actually 4 more cases than had been detected by the current detection methodology, which was a urine ferric chloride test. The method had also been applied to the measurement of phenylalanine in patients who were on a phenylalanine restricted diet. And so this paper was really the first to describe a method as it was adapted for screening infants prior to their discharge from the hospital. And I think it's very easy to say that this is one of the seminal papers in the field of newborn screening.
La parte histórica es el primer artículo publicado que efectivamente podría ser utilizada como screening. Había otros métodos, pero no se aplicaba a poder hacer screening de poblaciones de pacientes y representa el hito histórico.
So this is a picture of the bacterial inhibition assay that was developed by Dr. Guthrie and Ada Susi in Buffalo. The principle of the assay is really quite simple. The agar plate that you see here has been seeded with the spores from Bacillus subtilis, and the agar contains a growth inhibitor, beta-2 thionealanine, which is designed to suppress the growth of the bacteria. But this inhibition is reversed in the presence of high concentrations of phenylalanine. So if we look at the growth of the bacteria around the dry blood discs, this is related to the amount of phenylalanine that is present in that specimen. So in the upper row, you can see the calibrators that were used in the assay, going from lower concentrations of phenylalanine to higher concentrations of phenylalanine. Using that calibration, we can then spot an affected individual based on that growth of bacteria around the dry blood spot disc.
La fila de arriba es de control y calibración. Tiene diferentes concentraciones de un inhibidor de crecimiento y todos son bacilos spores que abajo, cuando vence el inhibidor, asoma como positivos, es que entendí bien. Y es una manera visual para identificar visualmente donde existe ese defecto genético en la muestra abajo. Son individuos los de abajo.
So this method was simple, fast, and inexpensive, and it allowed for the first time the ability to screen entire populations of newborn babies prior to their discharge from the hospital.
Este método es la primera que reúne facilidad, rapidez y precisión para hacer screening de eso en poblaciones infantiles en los hospitales.
So this report is now 60 years old, but I find it very interesting that some of the discussion topics in the paper are as relevant today as they were 60 years ago. So the authors had concerns about the number of false positive test results and looking at ways to minimize the number of false positive screening results. They were concerned about harmonization. So if this test could be repeated across multiple laboratories, then the information gathered from one laboratory could be applied to another. They also talked about the need for a confirmation of these presumptive positive screening tests, which should be repeated using a new blood specimen or a new plasma specimen and an independent phenylalanine assay.
Solo quería ver si estaba bien copiado y todo eso.
Doctor dijo, los autores de este primer ensayo hace 60 años querían que hubiera o existiera un método que cumplía con muchos de los requisitos como para poder hacer screening. Y en su opinión, sí lo lograron. Porque habían preocupaciones de falsos positivos, poder, organización, es en otros sitios tener el mismo resultado y cualquier resultado positivo confirmado con otros métodos. Y dice que lo lograron desde hace 60 años, por eso es el estándar y la brillantez de los que empezaron esa technique.
So if we fast forward now 30 years to 1993, you'll see the earliest description of the measurement of phenylalanine from dry blood spots by mass spectrometry. This work was conducted by Drs. Don Chase and David Millington at Duke University in North Carolina. And they were exploring the use of mass spectrometry for the quantitative measurement of phenylalanine and other amino acids from dry blood spots. They were able to perform a simple extraction of the dry blood spots and a mass spectrometry method that was able to not only detect phenylalanine, but also other amino acids such as tyrosine, methionine, the leucine isomers, valine, and others in a single experiment that lasted less than 2 minutes.
El siguiente hito histórico aquí fue en 1993 que pudieron generar o hacer una técnica que utilizaba sangre seca, secado, y detectar otros aminoácidos al mismo tiempo que PKU. Y fue un salto de la realización masivamente con mass spectrometría de masa.
So if we look at modern day mass spectrometry for the analysis of dry blood spots, you'll see the dry blood spot cards that are received in the newborn screening laboratory. And a single disc, approximately 3 millimeters in diameter, is punched from this dry blood spot card. And the metabolites of interest are extracted using an organic solvent that contains internal standards. And I'll speak more about the importance of these isotopically labeled internal standards, but they allow for the quantitation of the metabolites of interest. The extract from the dried blood spots is then directly infused into the mass spectrometer. So there is no column chromatography that is involved. It is simply delivering the extract in a stream of solvent into the mass spectrometer, where we can measure all of the metabolites of interest and calculate the concentration of these metabolites.
Entonces eso representa aquí ese slide, el proceso actual. Entiendo que vienen unas tarjetas, lo cual se hace saque un círculo redondo que va a la siguiente máquina, que no sé exactamente qué es, pero esto saca nuevamente metabolitos mediante un solvente. Entonces este solvente con los metabolitos son extraídos y pueden, o sea, evitando otros métodos más lentos y consiguiendo otros valores más bien cuantitativos al final.
So here's a closer look at what happens inside of the mass spectrometer. As I mentioned, the dried blood spot extract is directly introduced into the instrument. The metabolites are ionized, which allows them to be manipulated in the electric fields of the mass spectrometer. The most common mass spectrometer that's used is called a tandem quadrupole instrument, which allows us to select ions that are specific to the metabolites that we are measuring. I mentioned that we add internal standards, and we add them to every sample at a known concentration, which allows us to perform this very simple calculation where we look at the intensity of the metabolite of interest, in this case phenylalanine, and the intensity of its internal standard. And we derive the ratio of the metabolite to its internal standard and multiply it by the concentration of the internal standard. So in this example, if the internal standard for phenylalanine has been added at, say, 100 micromolar, and if its intensity is about 50% that of phenylalanine, then the concentration of phenylalanine in this specimen is approximately 200 micromolar. The value of tandem mass spectrometry is that the instrument can rapidly cycle through all of the metabolites that we wish to measure. So we can measure greater than 100 metabolites from a single dried blood spot in an analysis that takes less than 2 minutes.
Este gráfico indica el proceso dentro de mass spectrometer. Es introducido en como iones, como electricidad, y después pasan a un filtro que combina, o sea, que selecciona y mide, y a la izquierda abajo el gráfico se compara lo medido con un estándar y ahí saca una tasa entre el estándar y la medición. Y la ventaja de eso es que puede hacer muy rápidamente más de 100 metabolitos en cuestión de 2 minutos de análisis, y hace una producción muy alta para poder tener resultados fácilmente y muy altos.
So here are some of the very first mass spectra that were acquired using this technique. Again, this is work that was done at Duke University by Drs. Chase and Millington. And what you can see in these mass spectrum are a mass spectrum from a healthy newborn, 2 healthy newborns, I should say. And then in the lower pane, here is an example of a baby with phenylketonuria. And what you'll notice immediately is that the intensity of the phenylalanine peak is much elevated, is greatly elevated in the patient with PKU. And I've blown that up here to show the increase in phenylalanine relative to its internal standard, which is marked by an asterisk here. So there were 91 specimens from the California newborn screening program that were originally classified as positives. They were false positive screening results based on fluorimetry, which was used in the California lab at the time. When using the mass spectrometry-based method, the number of false positives decreased to 3 specimens. And when we include the phenylalanine to tyrosine ratio, it leaves just a single false positive specimen. So almost a 90+% reduction in the number of false positive screening results.
Este ejemplo realizado en en Massachusetts fue aplicado a unos exámenes realizados en California, al otro lado, con 6 falsos positivos, y aplicando esta metodología descartaron los falsos positivos y quedaron con 1. Es una comprobación de la precisión de este método. Y el ejemplo a la izquierda es el positivo de los dos especímenes normales. Siempre que...
So, in addition to amino acids, it is also possible in the same experiment to measure a profile of acylcarnitines. And here you see a dry blood spot from a healthy child and a blood spot from a child with very long chain acyl-CoA dehydrogenase deficiency, and then a baby in the bottom pane with long chain hydroxy acyl-CoA dehydrogenase deficiency or trifunctional protein deficiency.
Además, muestra aquí que además de procesar aminoácidos puede hacer perfiles en este caso, acetilcarnitina y detectar en debajo esos otros parámetros mediante ese método de mass spectrometry.
And so if we look today at the metabolites that we routinely measure in a single dry blood spot in just a 2-minute analysis time, you can see that we are now measuring in excess of 60 metabolites. So what became apparent in the early 2000s is that there were a large number of disorders that we could screen for, that it was capable, that the technology was capable of screening for them. But the question then became, what disorders should we be screening for?
Aquí está una lista comprensiva de lo que se puede hacer con esta metodología. Comenzando en los años 2000, logrando eso, quedaron preguntando cuáles son los que deberíamos hacer screening. O sea, ese proceso arrojó aproximadamente 60 metabolitos, pero cuáles valdrían para medir y poder trabajar clínicamente.
So in part, in response to this, the Health and Human Services Secretary, which is our equivalent of the Ministry of Health in the United States, commissioned the American College of Medical Genetics and Genomics to develop a panel of disorders that the Health and Human Services Secretary could recommend that every state include in its newborn screening panel. The ACMG released its report in 2005, and the recommended uniform screening panel was established in 2010. At the time, the recommended uniform screening panel contained 29 core conditions that the Health and Human Services Secretary recommended that all US states screen for. And you can see over the course of the last 13 years that a number of disorders have been added to this recommended uniform screening panel as guided by a panel of experts.
Sí, la siguiente meta aquí era con posibilidad de tanta información. Contrataron a un grupo de genetistas y otros para establecer cuáles eran los más importantes. Y eso fue, el reporte fue en 2005, en el 2010 determinaron mediante consenso 29 de la lista. Pero en los años vinientes, 2011, 15, etc., más fueron añadidos a medida que consiguieron de más importancia.
So if we look at the recommended uniform screening panel today, it's expanded from that initial 29 core conditions to 37 core conditions. And I think what's important to show here in the graph on the right is that nearly 75% of the core conditions on this recommended uniform screening panel are screened using mass spectrometry. There are a small number of conditions that are screened today using an immunoassay or chromatography or enzymatic assays, but nearly 75% of those core conditions are screened using mass spectrometry.
Regresando un poco el panel de screening, la meta era hacerle uniforme. Entonces, que cada estado de Estados Unidos tuviera el mismo panel. Entonces, esta metodología, si entendí bien, representa un 75% de los usos comparado con otras metodologías empleadas. Y de 29 subieron a 37 condiciones principales de buscar en ese panel ya homologado.
And this recommended uniform screening panel will continue to evolve as there is a process for adding conditions to the recommended uniform screening panel. It starts with the nomination of a disorder, which is reviewed by the committee. The committee then may or may not conduct an external evidence-based review for the condition. If they ultimately decide to add the condition, then they'll make that recommendation. And ultimately, the Health and Human Services Secretary will respond and decide whether or not the disorder is to be added to the recommended uniform screening panel. So here is just a list of the 8 conditions that have been added to the panel since its inception in 2010. And you can see also there are a number of disorders that have been nominated but not included in the panel. And typically this is because the evidence-based review did not find sufficient evidence that the benefits of screening outweighed the potential harms of screening.
Ok, resumiendo eso, el diagrama de flujo a la izquierda es el proceso decisorio de incluir o no condiciones de diferentes entidades científicas y burocráticas. 8 condiciones han sido añadidas últimamente y otros tantos a la derecha nominados pero no incluidos. Las razones de no incluidos eran para ver si justifica la inclusión o no, y además de comprobar la precisión en la detección mediante esa tecnología de mass spectrometry.
You may be familiar with this paper from Dr. Gustavo Barajo from Argentina. This is from the American Journal of Medical Genetics in 2021, where he surveyed the 20 countries of Central and South America to look at the progress that has been made in newborn screening and has outlined it by country. I think the most important point is that in the time since the previous report, that there's been observed sustained and significant growth in the last decade towards the implementation of national newborn screening programs. And today you can see that there are a number of countries that have either implemented tandem mass spectrometry or are piloting the inclusion of mass spectrometry for newborn screening. Today, only Costa Rica and Uruguay offer routine tandem mass spectrometry-based newborn screening for its entire population. But you can see that there are pilot programs in Mexico, Colombia, Brazil, and others.
Esto representa una mirada al continente, nuestro continente de Centroamérica, del uso de esa tecnología. Sí está avanzando, pero los países que están implementando es un interés, pero se está mejorando pues, el hecho de espectrometría de masa en Tandem, en conjunto. Es lo que se llama esa tecnología.
So also in that paper was an analysis of the number of publications in the peer-reviewed literature. And you can see over this period from 2015 to 2020, there were a total of 94 publications related to newborn screening, published from researchers in 13 different countries, which Dr. Barajo has concluded reflects the growth and interest in the research and implementation of newborn screening programs. So again, encouraging developments in newborn screening.
Hay motivo de esperanza porque en los últimos años hay mucho más publicación de temas de screening y está desarrollado por país abajo, pero está implementando mucho y es muy alentador desde la masa.
So in addition to routine newborn screening, as I've described above, using flow injection analysis, tandem mass spectrometry, mass spectrometry has also been applied to second-tier newborn screening tests. And the adoption of mass spectrometry for these tests has been increasing rather dramatically in the United States and in the countries of Europe.
Por segundo tier o plano, entiendo que del screening pasar a otro screening más completo y está en Estados Unidos implementando eso en la segunda fase de esta tecnología.
So I'd just like to provide a brief definition of a second-tier newborn screening test, so that it is not confused with diagnostic tests or follow-up tests. But a second-tier newborn screening test is an additional test that is performed on the initial dried blood spot specimen that was collected at birth. And when the initial results from our flow injection tandem mass spectrometry experiments are either positive or perhaps borderline, then a second-tier test may be used to try and determine whether or not it truly is a positive screening result or whether or not it is a false positive screening result.
La descripción de ese añadido al proceso aquí, primero no requiere otra recolección del espécimen y es útil cuando débilmente sale positivo en la primera prueba para separar eso y es para trabajar a reducir los falsos positivos básicamente.
And this is simply a generalized newborn screening testing algorithm that is commonly used. So that first tier screen, which I described previously, in the event that there is a presumptive positive screening result or an indeterminate or borderline result, frequently the labs will retest the initial specimen, or they will ask for a repeat specimen from the baby and repeat that primary newborn screen. However, if a second tier screen is available, then that screen may be employed to determine whether or not the presumptive positive screening result truly is a positive screening result. And if it is, then they will initiate the follow-up that is necessary by alerting the healthcare provider.
Este diagrama de flujo indica el proceder cuando hay una presunción de positividad. Y el segundo tier, o la segunda instrumentación, se aplica y mediante el diagrama de flujo comprueba, separa los falsos positivos y de ahí presenta como alerta para el paciente que son recién nacidos para el sistema para atender la parte médica.
And this is simply a list of the most common conditions that frequently benefit from a second tier screening test. So you'll see disorders of amino acid metabolism, organic acid metabolism, the congenital adrenal hyperplasia, and some other conditions that benefit from a second tier test to reduce the number of false positive screening results and to improve the positive predictive value of the screen.
Empleando la segunda metodología después de la primera, tiene beneficios de detectar todo lo que está en el dispositivo y aumentar la precisión en la conclusión de cada niño hecho las pruebas. Y ese es el beneficio de la segunda pasada de la misma muestra o de otra.
So in 2007, my group, working with Dr. Michael Bennett at the Children's Hospital of Philadelphia, developed a second tier screening test for the amino acids that are associated with phenylketonuria, maple syrup urine disease, and cystathionine beta synthase deficiency. So using a high performance liquid chromatography method, we were able to demonstrate that we could separate the isomers of leucine. So here in this inset, you see alloisoleucine, isoleucine, and leucine from a patient with maple syrup urine disease. And this is important because the initial screening method is not capable of separating the isomers of leucine because they have the same molecular weight and they fragment in the same way in the mass spectrometer. But we can separate them chromatographically so that we can distinguish between maple syrup urine disease and hydroxyprolinemia, which is a very rare and frequently benign disorder. We also applied this method to plasma to monitor patients who are confirmed as having one of these metabolic disorders.
El grupo de donde trabaja el doctor, que entiende que es una empresa, han desarrollado en la segunda metodología que están aplicando mediante cromatografía para detectar los isómeros de los aminoácidos y de esa manera poder separar enfermedades genéticas que con la primera método no se podían distinguir uno con el otro.
I won't go into too much of the detail on this slide, but it's another example of a second tier test. This is from Dr. Marzia Pasquale in Salt Lake City. This one is particular to disorders that are indicated by an elevated propionyl carnitine in the initial screen, but propionyl carnitine is a marker for 4 of the core disorders and 1 of the secondary disorders. So Dr. Pasquale developed a second-tier test that improved the positive predictive value of their screen from approximately 0.5% to 100% from 2016 to 2013. So in 2013, with this second-tier test, 11 babies were referred for diagnosis and 11 were confirmed to be true positives.
Okay, dice que solo hay 2 minutos. We have 2 minutes left.
Okay.
Just briefly, this shows an effort from doctor in Utah, un doctor en Utah, estado de Utah, que lograron con otra segunda generación de esa prueba mejorar de 0.5% a 100% de especificidad del diagnóstico.
So in the interest of time, I'll go very quickly here, just to say that second-tier screening tests have been developed for a number of disorders, including congenital adrenal hyperplasia. Here's a report from the newborn screening program in Wisconsin.
Dr. Reza, they say you have 10 minutes now.
Oh, okay.
Sorry, also long. La de segundo nivel es del anterior, es para conseguir mucho más especificidad y poder llegar a un 100% de diagnósticos. Y si entendí bien, hay diferentes sitios que tienen diferentes métodos de segunda metodología y están avanzando en la detección de errores genéticos en recién nacidos.
And our group has also worked on second-tier tests for congenital adrenal hyperplasia, where we are able to measure 21 and 11 deoxycortisol. And this allows us to distinguish between classical and non-classical adrenal hyperplasia, and also to distinguish between the more serious salt wasting form of adrenal hyperplasia and the simple virilizing form of adrenal hyperplasia. So again, being able to measure multiple metabolites from a single dry blood spot can add a great deal of value to the newborn screen.
Un poco en resumen, espero que la posibilidad de medir diferentes metabolitos con el método de segundo nivel y en el hiperplasia adrenal congénita permite detectar las variantes de esa enfermedad y distinguirlos de las otras variantes.
And then also just to show that the implementation of a second-tier screen can help to reduce the cost to the newborn screening program. This is some work that was published in, I believe, 2007, from Dr. Dieter Matern and Piero Rinaldo at the Mayo Clinic in Rochester, Minnesota. And what you can see is that without or prior to a second-tier screen for adrenal hyperplasia, and with a second-tier screen for adrenal hyperplasia, the cost savings is nearly 90%, going from over $600,000 for follow-up costs to approximately $62,000 in total follow-up costs. And you can see the great reduction in false positive results in 1 year from 710 to 41.
1 year this is.
1 year, yeah, this is from 2007. So this in the without second tier is prior to 2007, and with second tier is from 2007.
Ya, ahora entiendo. La implementación entre 2007 y en adelante la implementación del segundo método para detectar esos errores genéticos. En la primera fueron detectados 710 y con la segunda metodología de detección, los falsos positivos quedaron solamente 41. Y en términos económicos, la última línea de costos finales a los pacientes que llegan a determinar si tienen o no, bajó de $600,000 a $62,000, prácticamente 90% de reducción en costos de seguimiento y determinar si la enfermedad o no. Entonces, la implementación de la segundo nivel de esto tiene implicaciones en costos muy significativos, más del casi el 90% en ahorro de costos de hacer exámenes posteriores.
And finally, just to summarize, mass spectrometry has become an indispensable tool for population-wide newborn screening. We now have the ability to automate and process large batches of samples. We can measure multiple metabolites from a single disc taken from the dried blood spot that's collected at birth. And now we're seeing mass spectrometry, the use of mass spectrometry expand to include second-tier tests that can improve upon the screening specificity, reducing the number of recalls. And as we've seen from the data from the Mayo Clinic in one example, these second-tier tests can also be very cost-effective. And I'll just end my talk with a warning, and that is that cute babies grow up to be teenagers. And so this teenager on the left is Noelia, my oldest daughter. You saw a picture of her earlier from when she was having her dried blood spot collected. And this is her younger sister, Helena. And yes, so babies do become teenagers.
Voy a explicar lo más interesante primero aquí en la foto. Son las dos hijas del doctor. Y la una a la izquierda fue al inicio de la presentación, cuando estaba sacando la sangre para hacer el screening. Y son sus dos hijas ya jóvenes. Entonces, un resumen que la técnica de espectrometría de masa ha resultado con el tiempo muy indispensable para hacer el screening de los recién nacidos por su habilidad de automatizar y procesar grupos muy grandes de muestras. También después los diferentes metabolitos separados y detectados. Y la segunda metodología que explicó el doctor mejoró la especificidad y eliminando falsos positivos, y mejora el diagnóstico diferencial, y al final resulta muy efectivo, sobre todo la segunda fase de esa metodología. Con eso creo que termina.
So I'd just like to again thank you for your time and attention today, and thank you to the organizers for the opportunity to present, and thank you to Lance for the expert translation. The final slide I've pulled together what I hope is a list of helpful resources for you. Many of them I have used over the years, and I hope that they'll also be helpful for you.